So tonight we're going to talk about cardiac arrest and post-arrest care with us going through ACLS right now. A lot of folks that are needing those certs. This is the first class to go through the very new standards, the 2015 standards that are out. And so a lot of y'all are getting to see some of those. Now, some of y'all took it today. Not a lot of great big changes, but there are a few things that are changing. I'm all conscious about it. They say I talk with my hands nonstop. I guess I do, don't I? But it's okay.
You're walking downtown?
They said I look like Bart Rager trying to sell a car. So as we talk about the continuing education, guys, for the state guys in the room, this will be under medical for the NANTP, or the National Registry folks will be under cardiovascular, which will be added by us. So that'll make that a little easier. So some of the objectives tonight, we want to talk about discontinuous compressions. AHA is starting to recognize the importance of, instead of this 30 to 2 thing, but more of a little bit trending toward continuous compressions, which is something that as practitioners we do all the time. We also want to learn about the importance of early compressions, and we're going to talk about what dispatch's role in that. We'll talk about the crib cycle a little bit and what's going on with that. Understand the effects of anaerobic and aerobic metabolism, and talk about how that plays into effect with our cardiac arrest. And then we want to start, and we're going to explore the effects of the post-arrest syndrome. So let's look beyond the CPR. We all know that as we get on a 911 call, we're behind the 8 ball when we get there. The best thing is that patient will arrest right in front of us. But how often does that happen? Not very often. How many people in the room have had actually somebody arrest right in front of them? Well, a lot more than I was expecting. But it doesn't happen a lot, does it? Most of your cardiac arrests end up being, you get there 6, 7, 8, 10, 15 minutes afterwards, whatever it may be. And so a lot of times this can be, we're already behind the 8 ball. So 1 out of every 10 cardiac arrest victims we're actually getting. And as you can see in 2014, you can see the trends are typically 2014 had an exceptionally high number of arrests nationwide, and then kind of trended back down in 2015. But as you can see, now ROSC is one thing, that's great. We get pulses back, that's what we achieve, that's what our goal is in the field. But the thing is, are we making family reunions? Are we getting survivor numbers out of that? That's where it becomes important. And that's where a lot of factors come into play with the dispatch side, with what we do early on, with bystander CPR, with things that are happening, and how are we going to improve this process. So as you can see, in 2012, we actually had a pretty good number. Well, this is when we really started to work hard nationwide to start talking about, hey, we need to start thinking about this CPR thing instead of doing everything else that we were doing as advanced providers. And so we kind of stay around the 10 mark. If you average it out, about 10% of the folks are going home from surviving from cardiac arrest. So attention has been changed for not only doing continuous compressions, but we've really started, the odds are racking against those patients because they have so many comorbidities. They have so many things that we've got to battle. What got them into arrest, and then what do we have to do to get them out of arrest? And whether it be the BLS side, the ALS side, whatever we need to talk about, but these patients going into it already have the odds against them. But we have a ways that we can start to beat the odds, and that's why we're seeing a trend nationwide and starting to climb with survivor rates. Not only ROSC rates are surviving, that's great, so we're getting more ROSC rates in the field, but now we're seeing more survivor rates nationwide because we're really starting to emphasize people like King County in Seattle, Washington, doing an excellent job with training. In order to get a driver's license in Washington, you have to in Seattle, you have to have a BLS card before you can get a driver's license at the age of 16. That makes a huge impact over the people that are able to provide BLS care before ALS arrives. Now, as we're doing compressions, only about 25 to 40% of our compressions is of what the heart naturally creates on its own when it's beating. So the goal for us is, if we're only able to maximize our compressions out to get 40% of what a normal EF is, or a normal ejection fraction, I need to make sure that I get those pulses back quickly. Let the body do it on its own. Of that 25 to 40%, 30% of that blood flow goes to the brain. So that's a pretty good chunk of it heads upstairs to make sure we have cerebral perfusion. The body naturally says, I need that in my brain because it knows that's what it's going to have for neurological outcomes. So compressions first. This wasn't always the case because many years ago, as a lot of some of the old timers in the room, and I say that even in the last 5, 6, 7 years, we thought, hey, as paramedics, it's our job. We try to see who could get in the house, who could get a few compressions in, but who was going to get that IV and who was going to get the intubation, and how we were going to make things quickly. We're going to load up and we're going to go to the hospital. And we've proven over time that we can't do good compressions loading. We can't do good compressions while in transport. And so what we were doing is we were creating dead head on live body, because eventually we were getting pulses back. And we were doing the things that weren't important. Do I agree that intubation is going to be important at some point? Yes. Some point down the road, they're going to need intubation. That way I'm protecting that airway from when they have emesis later. And so these processes, these thought processes have changed. And some of us older folks in the room, that was hard. That was really hard for us to say, man, I got to stay on scene for 25, 30, 40, 50, 60, 70 minutes sometimes we've seen. And so that's a hard thought process for us to say, I'm not going to get in there and intubate real quick. I'm going to do these other things, and we're going to provide the basic life support, but I'm a paramedic. That's what I get paid to do. Or I'm an intermediate. That's what I get paid to do. I get paid to start the IV. I get paid to intubate. And that's true, we do at some point, but if we don't go back, we didn't start as paramedics, we started as EMTs. And we've got to master those basic skills as we move forward in this cardiac arrest process. However, most of the adults that suffer the non-hypoxic medical cause of cardiac arrest, studies suggest that they actually have enough oxygen available in their bloodstream to last a little bit. And so some of the literature is suggesting 4 to 10 minutes, out to 10 minutes of oxygen supply. Well, if the oxygen's present, my job is to get that oxygen around. So that's where I've got to do my compressions. It's not about the ventilations at that point. It's irrelevant for us to ventilate them. They've already got oxygen present. It's our job to get that around. And guys, I want to tell you that's something that the comm center's done an incredible job, because I QI that from the comm center all the way through discharge, and typically those guys are hands on chest in 30 seconds of the phone call. That's where our survivors are going to start. Yes, it starts with us getting there. It starts with you guys getting as fast as you can, us getting there as fast as we can. And that's great, because we're going to say we're the trained professionals. That's what we do, is great CPR. But the thing is, if I'm not doing anything before then, I've got 5 to 6, 7, 8, 9, 10 minutes in reality, and that's only if I'm sitting here watching when Tucker goes into arrest and I make that call immediately. We might be there hands on chest in 7, 8, 9, 10 minutes. But if he laid there for 15 minutes prior to anybody finding him in the bathroom, and then somebody goes in and says, oh, now we got a call, we're already way behind the 8 ball. So the quicker that the comm center can get hands on chest, and that's one of the biggest pushes by AHA this year, was to get hands on chest as soon as possible by the comm center. And they've done a really, really great job by getting that on there. And I'm seeing your documentation showing people, and even on, I hate to say it, but we even had some signal 28s. And PD says, dude, why did y'all move them? Well, the comm center told us, the dispatch, when we called, they said to move them to the floor and start compressions. Well, to a layman, they don't know rigor mortis, maybe. They don't know the signs that are incompatible with life. So they're doing what they can. It's easier for to defend something that we've done instead of something that we haven't done for that patient. So we want to get them in the floor. Yes, it may be a signal 28. Yes, it may create some investigation problems later on the road, but we've at least done the right thing for the patient at the right time. So as we move forward with more and more research, guys, there's more and more people looking at these out-of-hospital arrests. Because what they're finding is, and Dr. Myers out of, now AMR, but originally out of Wake County, he's very strongly and says, along with Dr. Eckstein out of Los Angeles Fire Department, has said, if you don't get them back in the field, don't bring them to the hospital. It does us no good. Because if you don't get pulses back soon, that natural compression, that natural blood flow, they're not going to survive if they don't have that. And so they've been very prominent about making these stances, and there's more and more people that say we've got to get compressions quickly, we've got to get defib quickly, and then we can start moving to airway and IVs and stuff on down the road. So now they moved to this term cardiocerebral resuscitation. Because in the past, I would venture to say we were totally on the cardio side. We did a few compressions. We were really good at the intubation and the IV and the drugs. And we might have got something kicked off with the heart with a little epi or with whatever we've done, but it was minimal. And guys, it's kind of sad to say, but our ROST numbers originally back in 2007 was 7%. That's poor. Because we were focusing on, that's what we were told by AHA, we need to get intubation, we need to get IVs, we need to give drugs, and very little emphasis on compressions. And so our ROS numbers were very, very poor. So if it was your family, 7% is not a very good chance for them. Versus now, we're in the 68th percentile on return to spontaneous circulation with Defib TAC. So those are incredible numbers, incredible turnarounds of what we're doing in the field. When we're pumping the chest, what we're doing is we're pumping the brain. If I'm not providing that flow, and remember, only 30% of it's getting up there, of the 40% I'm creating. So the cerebral pressures are not all that great, but it's enough to sustain life, enough to keep things going, enough to keep it neurologically intact until we can get that process started back on its own. So that's the goal, is of course, we all understand that. We've got to get pulses back as soon as possible to make this happen. Historically, cardiac arrest studies really didn't address final neurological outcomes. Nobody ever really thought about following them all the way through the hospital and saying, are you going home and having family reunions? The only thing we cared about for a long time was, are we getting ROS numbers? That's all we cared about. What was the ROS grade? Did you do your job in the field? Yeah, I did my job in the field. I got pulses back, but did I make a neurological outcome? And so that's when we've got to change our thought processes. In a landmark retrospective study of 1,019 patients that was done, and these were non-traumatic out-of-hospital arrest in Arizona alone, witness V-fib with continuous compressions and 6 minutes of passive airway survived 38.2% of the time. Wow. Astronomical numbers. Now, we all know if it's a witnessed arrest and I get hands on chest immediately, that's the best chance they have. Because I've got oxygen to the brain, I've got oxygen to the myocardial immediately. The witness to defib arrest, the traditional 30-2 method, that dropped down to 25.8, which is still a pretty good witnessed arrest number. But if it's my family, I want the 38.2% because it gives them a better chance of living. It gives them a better chance of being able to see their children get married or their grandchildren or whatever it may be. It gives us that better chance of trying to make that outcome. Other studies followed with most, and they've most reached the same conclusion. Uninterrupted compressions may offer a better chance in ROS and good neurological outcomes. That's not rocket science. We know that. We've proven that over the time and things that we need to do to make that better. What is the greatest benefit to passive airway? It buys us time. Whether it's a 3-man pumper crew that gets there first, or 2-person EMS crew, or a mixture of the two. There's so much that's got to be done in the first little bit. We're going to talk about the very first little bit here in just a second, that the less I can do invasively to get my hands on the chest to make sure our compressions are great. And guys, we've been watching compression numbers, our CCF, our total fraction of a proper rate and depth. And it's been amazing lately to see, and for AHA for the first time has defined that as saying 60% is the minimal standard. And we prefer to see that at 80%. That's what AHA for the first time has defined. Now, you look at cardiac arrest in hospitals, not a lot of places have devices that are able to measure depth and rate right now inside of a hospital. In fact, I'd venture to say nationwide, there's very few EMS services that have the technology we do. And so we have an advantage already going into it. There's nothing better than seeing whoever's running the code or if it's a lieutenant or whoever's back and saying, hey guys, you got 15 seconds to go. When we get ready to change, you here, you there, let's make this as quick as possible. Let's keep our coronary and cerebral pressures up. Let's keep our ATP present. And let's get those processes going very quickly. Passive airway, once again, does not, it buys us time. It also allows the pressure to get off of the vena cava. So I'm not hyperventilating my chest. I've got I got more blood flow increase to the inferior superior vena cava that's getting my preload that's going to increase my afterload with my compressions. That's the science behind that passive airway. But we know that we've only got 4 to 10 minutes worth of oxygen. We do know we draw in when we're doing compressions, we're getting some in, and eventually we need to get to ventilating them at some point. And that's about minute 7 to about minute 10, somewhere in that neighborhood. There is places across the U.S., even in some here in Texas, that don't even go to an intubation at all. They leave them passive airway the whole time, either death or ROSC. If they get ROSC, they intubate them. And so the science is still out on some of that, but AHA is now recognizing passive airway and saying, whoa, this is working really good. And it's buying rescuers time to be able to do the basics of what's needed instead of tying people's hands up and going straight to ventilations. What about the time to defibrillation? The first few minutes is absolutely critical. One of the first questions the communication center asks, is there a defibrillator available? Now at my house, I don't have the $2,500 to buy a defibrillator. So it's one of those things, it's kind of hit and miss. But most businesses nowadays, there's a lot of places that have defibrillators readily available. The nice thing is, as many stations as the fire department has, it's great because they're pretty close. They can get there quickly, get their defibrillator in the house. If CPR's already started, I've got my circulation period, I'm getting ATP and oxygen going. When these guys get here, or Foxtrot gets here, or you guys get here, whoever gets here first, get the defibrillation in play and get that heart defibrillated quickly. As we know, the first few minutes of the arrest is the first 1 to 4 minutes is the electrical stage. Now, not all cardiac arrest goes straight into VFib or VTAC. Some of them do go into asystole, but if we're going to have a chance, minute 1 to minute 4, that's the electrical stage. Past minute 4, from about 5 to 10, that's a circulatory stage. That's where if I'm doing good compressions and I'm cycling that oxygen and that ATP and getting it around, I have a chance of defibrillating it because I have stuff there that the muscle can work with. After minute 10, it starts to get a little bit futile because we move into the metabolic stage. I would venture to say, unfortunately, this is where we arrive a lot of the time. We are already way behind the 8 ball. So not only do we have the comorbidities, what got us into the cardiac arrest is a problem, but now I've got time factor. Did they find Tucker immediately? Or did his wife walk over him a couple times and say, whoa, we'll just come back? He did look good, but he'll be okay. I mean, you don't ever know. And so you got to kind of weigh that. I threw you under the bus with the wife too, so already. But you've got to weigh that of at what stage are we in? Am I saying it's futile to start in the metabolic stage? Absolutely not. If there's still signs, there's no lividity, there's no rigor mortis, then yeah, I need to start that process. If they're warm, I need to start that process. Once again, it goes back to it's easier to defend something we've done for this patient than something we didn't do. Of course, not everyone is a candidate for passive airway and defibrillation. Let's talk about that a minute. This was a pediatric traumatic arrest. Well, we all know pediatric, first of all, the number one cause of pediatric arrest is respiratory. And then if you add the trauma element to it, guess what? That's bad news. This was a call where the 311 got there. This was a 9-year-old that was ejected from the vehicle, was found in the intersection. Lubbock Fire got there on scene. This is their report. Very, very, very nice job documenting. They gave very great detail of where cars were, where the patient was, talking about exactly what they found when they got there, talking about how they got there, and they got their AED on. It advised no shock was available, no shock was advised. But the trick is they got there quickly. They started compressions quickly, which made for a neurological outcome. Now we all know going into this, blunt trauma, especially in a child, not a good situation. Not a very livable situation. Our crew got there, once again documented, hey, LFR got there, started compressions, it was appropriate. They noted by the time our crew got there, LFR had ROSC on a 9-year-old traumatic arrest. Wow. That tells you that those compressions were appropriate, they were quick, and they provided what the body needed quickly. Oxygenation, once again, they went ahead with the BBM. Great job of not going passive there. They understand that it's a 9-year-old Pediatric trauma arrest. I've got to ventilate all over it. Great job ventilating quickly. We got there, guys got intubated very quickly, the child did. They had pulses at this time, no gag reflex, did not have to knock the kid down. Very good documentation over what they found. LFR was performing chest compressions, first in this personnel approach. They did a quick rhythm check and they had pulses. Got the ET2, got them on a board, made the transport to the hospital, showed that the first vital sign they got, so what? I didn't have a blood pressure? I don't give. Doesn't matter. People say, well, that wasn't a complete vital sign. It had pulse on it, didn't it? Sometimes that, and guess what? All the way to the hospital, that's all I have. I document where it is, radial, yeah, we'd love to have a number there. But if I've got radial, femoral, carotid, what do I have? That'll tell us a lot of things. Once again, child went back into arrest, started compressions again, got an IO in, got some epi in, got things going again, and got ROSC. Then we get a number, 107/51. For a 9-year-old, is that normal? I'd say it's pretty close. I'd have to get the book out to be, do all my math. But that's pretty close. Now, 87 on a 9-year-old traumatic arrest, is that where you? Yeah, we got some issues there. What's the cause? Okay. We're about to talk about the cause. Here's when we got to the hospital, the ED snapshot. You can see, doesn't look very pretty, does it? Probably got some type of anoxic injury, maybe hurt the heart a little bit. We got great end titles. They're kind of low, but we got great end titles there. We're at 26. Respiratory rate of 21. Is that appropriate for a 9-year-old? You bet. Did a very nice job managing this kid. Pulses were maintained in the ED. Diagnosed, the child was a internal decapitation. As you can see, the MRI exam right there, this is this is supposed to be less than 1.2, and this is where the dislocation was from C1. They took the child to the OR. They did a C1 to a skull fusion. They ended up having a pneumothoraces. They've got, they did the cranial cervical fusions. They lost pulses again. This child lived 17 days. What you guys did was give that family some time to say goodbyes. Internal decapitation is not going to live. This was an unsurvivable injury. I got a phone call from the PD intensivist and said, I need you to come up immediately. I came up. This was after case review last time. She said, the parents want to see y'all. And they want to tell you incredible job as their child was dying, because it gave them time, because we did great compressions, we did oxygenization, we did the things we needed to do. It's pretty much unheard of. Dr. He said in all of her years, this is only the 3rd one that ever made it to the ICU. This is the longest one that lived in the ICU. So you had an insurvivable injury that you made survivable for a little while. That is remarkable, because you gave that family some time to get closure. I don't know if that helps. I don't know if that hurts. I don't know if it'd be easier to say goodbye that day or wait 16, 17 days and let them suffer. But I would imagine as a parent, because I have babies, that it'd be important to me to get to try to be as much as I can, to be there with them. So incredible, incredible job to the crews. Kudos to them.
I'll just add to that, now we can look back and say, okay, this patient really had almost an unsurvivable injury. I don't know that I bet if we looked enough, there's somebody out there that's had this injury that lived normally, but we don't know that in the field, right? I mean, we can probably go find a case of a very similar trauma that we've revived, and it's somebody's kid and now they're a parent now. So, we don't always know that. So sometimes the end game is it was better closure for family. Maybe it's organ donation. There's other ways that ultimately can play out there. I don't really have much more to add to that. We kind of threw the pediatric trauma, which passive oxygenation we don't do in pediatrics, and we don't do in trauma. I think everybody's pretty good with that. And we've been doing passive for over a year now, right? A year and a half, 18 months,
yeah.
You say? And our ROS numbers in our survival numbers, they haven't just skyrocketed, they certainly haven't went down. So it's still something I think that we should believe in and continue to do. There's certainly data that backs it up. So I know it's been a little rough just trying to get into that lingo of doing this passive oxygenation. Forget about that airway for a little bit, but it really does potentially help. And it certainly, our data doesn't show that it's hurt anything. Do you have any questions so far?
What's the percentage of gas exchange that takes place with compressions and passive?
I couldn't tell
They
you.
say 17% is what I saw not too long ago, just in random, about 17%. And, I mean, 21's perfect for oxygen, but that's where you're looking is about 17% on the exchange rate with negative and positive pressures, somewhere in that neighborhood. A little useless knowledge. Let me add another thing to that, though. When I went up there, Dr. took me in the room, and this child followed blinking commands. Unheard of, pretty much, with this injury.
Well, I have to and go back a slide. I mean, I really have to wonder, 17 days, that's a long time to live after a pretty severe trauma that we're saying most people won't survive. Anytime, once you survive that first 24 hours after a major trauma, your chance of survival is better. But then you kind of get to this other phase, if you start looking at ICU, more long-term medicine, but things like this, 102 fever, probably had some sort of,
With
Yeah.
a memo.
and probably was a hospital-acquired pneumonia. We use that term, hospital-acquired pneumonias. After we've been intubated, we have all these bugs in the hospital and in the ICUs. I mean, that in and of itself kills people. That's got a high mortality rate. So you start to have all these secondary issues, infections and sepsis and septic shock and hypotension that raises your mortality after you kind of get through those first few days of trauma.
So we've talked about the trauma arrest, and now let's move into the medical side. Any questions on the trauma side? We understand that's a load and go, it's a quick, need to ventilate, I need to do those things. And that's what happened. Once again, guys, kudos to the guys that were there, the ladies that were there, that made the difference that day. Because you made a difference in a family's life. Even though it was a bad outcome, you made that difference for that short period for them to able at least to communicate some. So let's understand the energy behind this cardiac arrest, because this is where the science starts to come in of why we're doing the things we're doing with compressions. So we have our glycolysis, okay? And this is where our adenosine triphosphate comes in, our ATP is built. I can shock a heart all day long. I can defibrillate a heart all day long. I can do compressions all day long. But if I don't have fresh ATP, and if ATP is not there, it just doesn't work. Glucose is transported into the cell through various modes. It comes in and it starts to bind and it starts to build. And these two molecules come in. It's a direct source of energy for the cell. So the muscle, the cell muscle, especially cardiac, eats ATP extremely quickly. We've talked about this many, many times. Once compressions start, the studies say 4 seconds, there's no ATP there. It also says anytime I stop compressions in 4 seconds, CPP or coronary or cerebral pressure is no longer there. Oxygen, it's the bonus. That's what switches over to where our pyruvic acid, high energy chemical binds, and it starts to really kick off and it starts to build these energies. Now, they still need the oxygen to start things going. Some of y'all may remember the Krebs cycle from chemistry class. Some of you try to forget it after chemistry class. It's irrelevant to us today, but it's pretty amazing how it works. But what happens is through this Krebs cycle, there's 34 different additional molecules of ATP that begin to build. And so I have my 2 molecules that build naturally, and then I have my 34 that come in with my oxygen stage. When I start to build, so it gives me 36 total build. Now, yeah, I'm throwing all these numbers out, but you got to understand if I'm not doing compressions, if I don't have the sugars present, if I don't have that oxygen exchange present, I'm not building this. And if I'm not building it, I have nothing to work with. When oxygen is unavailable, energy produces only occurs in the cytoplasm. And so this is the anaerobic state. And so not only it becomes a lot less efficient for what's happening. This is where we start to build our lactic acids. We've talked about lactic acid studies in the field. Is this something, you know, they have glucometer looking things now that can draw lactic acid in the field. That tells us what's going on with the body, and it starts talking about survivability. They weigh that quite a bit once you get to the hospital. That's why that initial blood draw is so important. Where did we start and where are we going? Anaerobic metabolism increases that, so I don't have the oxygen present. It builds that lactic acid. The pH begins to drop very quickly. We know that. That's why we give bicarb. Is to try to counter some of that. Now during cardiac arrest, some acidosis is actually good for us. So we lock it a little bit, but when we start to get dangerously low, that's why during prolonged arrest, we may give them, or we think they've been down a while, we're giving them bicarb in the field. ATP depends on sodium-potassium pumps. So we know that if the sodium and potassium is not pumping, my myocardial has to have that in order to function. Most enzymes work within a very tight range of pH. That's why we don't want them at 6.9. But if they get down to 7.2, that would be okay to work in that area. Now, I wish we had a way to get that in the field. And I think eventually in the next 10 years, we may have that capability to where we can start treating that a little bit better. The thing is, once we get into a very acidotic stage, I start to tear all my cells. Well, if I'm tearing those cells, the ATP is no longer there, the oxygen is not able to build, my glucose is not able to get in there, and my ATP goes away. That's why I've got to get my pump started on its own naturally to help with that blood flow quickly, as soon as possible. This is a 50-year-old male with Bystander CPR. Crew did a great job with documenting. The CPR was started on initially called by the 911 to 911. The bystanders on scene were unable to identify who found the male, but they found him out in this parking lot. CPR was started immediately by the bystanders, which got the blood flow going, which got the ATP and the oxygenation, the sugars going. The patient was found lying supine, once again with CPR. Very good documentation. By the time EMS got there, weak pulses were noted. Once again, we're showing if we start that basic portion and keep that perfect CPR, and Shelly's a prime example of that because she made a huge difference in a young man's life to where he's able to go play ball again. I got to go out last Friday night and watch this young man play ball who was in cardiac arrest last year. And the only reason he was able to do that was because he got what?
Good CPR.
Good CPR, and when did he get it?
Immediately.
Immediately when he hit the ground. And so that's what makes these differences, and we're seeing it more and more documented that we're getting CPR started by the comm center and moving quickly into that. We're seeing more and more times. Today they had another one. CPR done immediately on scene. When the crew got there, we had weak pulses. We're providing the things that need to happen. Cardiac monitor was put into place per protocol. We were in VFib at that point. So we had, we got an airway, we got passive, we went back into arrest obviously. Got a quick defibrillation in, got an IO present. So once we got pulses back, we got oxygen, we got ATP moving. Theoretically, I may have, once I stop again, 4 to 10 minutes roughly of in the circulatory, the electrical phase again. So I provided what it needed, I got it going again. Now it may not be totally that 4 to 10 minutes at that time, like we talked about originally, because the heart was sick to start with. But theoretically, I had the things that they needed. So with both the EMS crew and the volunteer fire crew, they stayed busy working the arrest, defibrillation, got amiodarone, more defibrillation, Narcan on board, epinephrine, got an intubation in, very good documentation of exactly why. And then the tube was verified, even got to double sequential defibrillation. That's something we're seeing pretty often now. We had 3 last month. Pretty good numbers. All of them were a conversion. All 3 of them were a conversion. So it's telling us we're not making those thresholds with our original defibrillation. So with that double sequential, it was actually at 320 joules biphasic, we're able to get that and meet that threshold.
Do we know what their survive rate?
2 of them went to Covenant. I've put in to get the results. 1 of them at UMC, and he did survive. So that's the rough right now. But I should have those in the next quarter. Chest compressions, once again resumed. We've got bicarb. We talked about that pH. We've been down a while. Let's go ahead and start to bring that pH up a little bit. Epi, then they started the lidocaine bolus and lidocaine drip. Another double sequential. If the amiodarone's not working, then we got to keep that process going and try to get another antiarrhythmic on board. Second IO was established. So we got 2 accesses now. Continued once again, another double sequential. And finally, yes, they got conversion with a 12 lead. Had even a good blood pressure without dopamine. 131/69 with a heart rate of 70. End titles are showing 18. Ooh. What's the cause of that? I don't know. It could be the acidosis. It could be to the point where I'm so acidotic I can't handle the CO2 and I'm letting it all go. I don't know. It could be just poor perfusion. It could be a sick pump. But with a good pressure, I would probably say that's probably secondary to some acidosis, some very severe acidosis at that point. Something we got to kind of weigh. What can we do with it? So there's the 12 lead. Looks pretty nasty. Looks very nasty. This patient needed to go to the cath lab pretty much immediately, like yesterday. But as we talk about our compressions, once again, you can see everything in the 2 to 2.5 range is meeting the mark. And we got a couple of the strong guys that got on there and got a little deep, but we got some good compressions. We stayed right where we need to at 120. And as you can see, there's very, very, very small breaks in my defibs. So as you can see, compressions to shock was 1 second. Second one, 1 second. Third, 1 second. Fourth. Now the fifth one, 3 seconds. Okay, that's still within the threshold. But then when we're getting back on the chest, look at those numbers. 0, 0, 0, 2, 2, and 3. So it tells me they're doing great compressions. They're providing the ATP. They're coming off shock right back on. That's what you've got to have to keep that ATP present, because within 4 seconds, we know the science that the ATP is no longer there. As you can see now, their target compressions was 60.15%. That meets AHA standards. Do we have room to improve on that? Absolutely. But as you can see, and this is what we normally see, right here is you got a total of, the total was 2.3 inches depth and 108.75 on the rate. So they did a very nice job managing this patient with compressions. So the outcome. The patient was admitted to the hospital, ended up having a new left bundle branch block. Well, if that's all he came out with after this, we did pretty good. But it was positive for cocaine. That changed our thought process, because if we got a long time user, what do we know that does to our heart? That's problems for us, okay? That's a comorbidity that we did not, that's not a normal medical one that we have to deal with on a regular basis, but that's what happened. So day 1, emergency room, when we get there, 7.1. So we talked about that at that end-tidal CO2 stage. We talked about our troponins. Our troponins positive. Lactate pretty high at 10, so we know we're spilling. We're in an anaerobic state at that point. Obstructive coronary disease, 95% blockage. He got stented. He started a hypothermin. They target controlled temperature, because that's the new word. Then they kept him there. They on day 2, day 3, they started to wean him off of everything. Day 5, he did start to get some cellulitis, some coffee ground emesis. GCS was 3 on day 7. Developed some edema in the upper extremities, and then the family requested DNRs. But as what we did here is we provided that family some time for closure. Once again, early compressions, early defibrillations, and very aggressive management. Very good documentation on this. Treg Teague, this is Treg Teague's report. He got report of the month, gift card to Cabela's. So very good job documenting, very nice job with that.
Who in here has done double sequential? Quite a few, right? Not quite half, but I don't know what I guess we haven't looked at our exact numbers for survivability, but I know we've had some in the past and even some recent. So, that question is, well, if we weren't doing double sequential, what would have happened? And who knows, maybe on this one, the third normal one would have got them back, but very well, perhaps they didn't. The other thing I just wanted to mention, whenever I read through here, this patient was found unconscious like in a parking lot, right? Just don't forget, or somebody, we did the right thing, getting right on, doing the CPR, but don't forget kind of a quick eval for trauma. I mean, if you haven't seen, at some point you will see the same patient, you'll transport them, and then you'll hear, oh yeah, remember that guy you took, he had a bullet wound back here, or something of that nature, and it was actually trauma. Other than that, I don't really have much. I will say, on the double sequential, usually the VFib that we just can't get fixed is usually some sort of cardiac event, a STEMI or some sort of lesion, which this was the classic patient. We've also talked about, or it has been talked about, like if you have a persistent VFib and you just cannot, even when we do double sequential, can't get them shocked out, should those patients end up going to a cath lab with active compressions and trying to restore the vessel? Because most of those probably have a 100% LAD or something somewhere, and that's why we just can't get that heart back. But I think that's still maybe in the future, not something we're doing now. Any questions?
So we talk about the lidocaine use with this. This guy's sodium was astronomically high. How does lidocaine work? Sodium blockade. And so that might have been, I'm not saying it is, I'm saying it might have been that kitchen sink method. That was what helped convert him later on along with the double sequential, because it started blocking that sodium out. Just a thought, if we could have got that blockade in earlier, I don't know. You've got a little bit of sodium blockade with amiodarone also. So maybe the combination of the two started to block some of that. I don't know. It kept him in VFib for a very, very long time. Hey, but we got pulses back, so now it should be smooth sailing from here, right? No. So how many times do we get them back and, we start to get stabilized and we get a little bit of dopamine on board or whatever may happen, and we start to move forward with this, and we're getting ready to package, and we go back into arrest. And so we've got to still battle the post-cardiac arrest syndrome. This is a major cause of the mortality, even though we fixed the problem of the cardiac arrest, whether it be high sodium, high potassium, we gave them a sodium blockade, potassium blockade, whatever it may be, with your amiodarone or your lidocaine, but they've still got a very long road to hoe ahead of them. We talk about the massive immune response. As the body during cardiac arrest, about 3 hours after, the body really starts to have an inflammatory response. So all of your organs, all the organs are being attacked at this time. Cells are being damaged. The ones that lived through the cardiac arrest, that were able to still carry ATP and the sugars and the oxygens, now that they are getting attacked again by an inflammatory response. This is things, the heart, the kidney, the brains, the liver. You've got all of these organs starting to be attacked. And so now you start to have this multi-organ shutdown. So we fixed the problem to get them out of cardiac arrest, but now we have coagulation issues. So we have microemboli starting to break. This is why a lot of those will stroke later. They start to throw clots places that we don't need clots to be going. The restriction of adrenaline, once again going through the brain, we're starting to get that response going. We've given a lot of epi, we've got a lot of squeeze going at that point. And now I start to have that vasodilatation, so I'm starting to lose my cerebral and coronary pressures again. That's why we need to give them a little bit of levo, or which coming pretty soon, here in about 18 days, we'll have levo on board. And so then on top of that, your leaky vessels. So you're not able to hold that ATP, you're not able to circulate that. So this is part of that syndrome that keeps going around and causing us more problems. Cardiac arrest, the brain injuries, the hypoxia, the emboli that may happen, the things that may put them into a coma long term. This is also the reason in the ICU, this contributes to about 66% of the out-of-hospital arrests end up dying from post-cardiac arrest syndrome. 25% inside the hospital. Typically those are more witnessed in the hospital than they are going to be in the field. So the patients with survival of the initial, once they survive the initial cardiac arrest, they face an overwhelming response that they've got to try to battle through to have few cells that are able to participate at that time. So we want to improve their chances of survival. One of the biggest things is a quick ROSC. Let the heart beat on its own so we can get that maximum EF or ejection fracture to where I can perfuse my brain. I get natural oxygen and cellular turnover through the Crib cycle, and we want to make sure that we're pushing that through. So once we get there, and this starts with the comm center, hands on chest quickly. We've talked about that so much tonight. We talked about the hemodynamic support, the oxygenation support. Once we get pulses back, we need to make sure we're trying to keep a map of about 65, a mean arterial pressure. I need to give the dopamine, I need to give the lidocaine that we're going to be, the levofed that we're going to be using, or the norepinephrine. Don't focus on getting 100% O2 saturations. They're not going to have the vessels to carry it properly, but we do want to strive for about 94%. We also want to keep our intervals between 35 and 45. That's going to help manage our acidosis side because I'm exchanging that CO2 out. But we don't want to hyperventilate. Target temperature management, we've talked about that. We stopped using cold fluid in the field. AHA came in and said this is a class 3 hazard. Basically, it's what we did, and we was doing such a good job getting 2 liters of cold fluid on board, we were flooding them nationwide. So they said in the field, stop, but keep with the cold packs, and we need to start target therapy quicker. It needs to be done over a slower pace. Is what this does is it decreases for every 1 degree Celsius or 1.8 degrees Fahrenheit, it reduces oxygen consumption in the brain by 7 to 8%. So if I can lower this 4 or 5 degrees at 4 times 7, that's 28% of oxygen reduction that my brain's requiring to use on a regular basis. The goal is to keep the free radicals down. To keep the, we also want to do this for 24 hours to the hospital at least, and then we'll start to warm them up slowly. Any questions? You had to do it one more time.
What's the word?
Glycolysis. She loves this. Okay.